Okay, welcome back. Welcome back to the session. In this talk, it's really unique and kind of niche, but really important. So I'm hoping that you all gain something from this talk by Scott Thompson. For those who weren't able to join us for his last quality sessions, and I'm going to just reintroduce his bio. Scott Thompson is the Prime/QIP project manager for UC Irvine Health, managing Medicaid waiver performance programs from DHCS and CMS for the health system. Prior to joining UC Irvine Health, he held CIO, COO, and VP/development roles in Managed Services Organization, a Medicare Advantage health plan in Puerto Rico, and several software development companies delivering EMR, clinical training and management, and UM/case management applications. His clinical background includes associate nursing facility and CCRN in a combined trauma/critical care unit. Welcome, Scott Thompson. Oops, having a bit of trouble hearing you there. It looks like you're not muted, but
I'm double muted. That's
there we go. Okay.
I'm overly muted for it. Okay, going to share my screen so you can see the slides here. And I think it is this one. So you should be seeing the banner for the, I did that right?
Yep, you're good to go.
All right. Well, good afternoon, everybody. And thank you for joining. And I'm going to go through I like to joke an exciting topic here about quality metrics and government programs. Nothing better for an afternoon discussion out here. So as I talk, I've got things that I want to go through and talk about, but at the same time, if you have questions, feel free to chat them in or raise your hand or just enable your microphone and yell out. I'm very glad to answer questions as we go. And there will be a question section at the end as well. So in a number of different programs or talks here, you've been going over, how insurance and care and the federal government and state governments and everything are all kind of mapped together. And today, in this session, we're going to talk about two specific terms, which is related to Medi-Cal or Medicaid programs, is be the more official name, but really looking at disproportionate share hospitals and facilities and how those, what's that for? And how is it, why did it come about? What are they in practice? And, why are they part of this kind of mix that we talk about in insurance coverage? So assuming that we're all on the right page and I'm talking about the right thing here, I'll go on to the next one. I'd like to remind everyone, because we're largely UCI based here, but for those that might be calling in also, UC Irvine is a full service hospital. It's large in the scheme of things compared to hospitals nationwide, 400 beds, currently larger with our, we have tents out front because of COVID and everything else, but we do a lot here and a lot goes on at UCI, and we touch not only a lot of inpatient work, but a lot of ambulatory and outpatient work as well. So it's a huge environment. There's probably not a facet of healthcare that we do not touch or do here in some capacity, in some volume here around it. And one of it has to be with that we do treat a significant number of Medi-Cal patients or Medicaid patients here for it. In case later on you ever want to get in touch with me, this is my contact information as well. And I don't have any financial issues to disclose here either, kind of standard start off stuff. So there are a couple terms that we're going to really focus in on this and where they come about. As I've said, disproportionate share hospitals, and also what are called safety net hospitals and how that relates to Medicaid programs and patient care and the compensation for that. But let's get a couple terms down. This may be repetitive for some, but just to make sure what we're talking about. When you look at different types of hospitals and these terms that we're going to be using, I'm kind of using private hospitals to mean they're owned privately. They are often either for profit or mission based. I mean, there can be different combinations, but in general, private hospitals have private ownership for them versus public hospitals like UCI. We're a public hospital. We're owned by the state, run through the university system. There are a number of them, I think 20 some odd, just here in California. And that kind of forms the two genres of hospitals that are out there, private and public for it. Now, there's this idea of what's a safety net hospital. So here's a whole other term for it. And safety net hospitals were targeted, if you look at their charters, were to focus on hospitals or identify hospitals that serve vulnerable populations, the poor especially, but that can be done because of impact of certain geographies that they're in. There can be other things that can be used to say this is in a safety net hospital in a vulnerable area. And then there's the idea of disproportionate share hospitals, and this has come to mean hospitals that are serving a large or a substantial portion of Medicaid patients, usually out of proportion for the area they're in, meaning other hospitals may not be at the same rates of treatment, and they do, and that has certain financial impacts of facilities. So they've defined these terms. So let's go through how these came about and what they're for, and to really kind of develop the thought process of why safety net and disproportionate share was even necessary. You got to start with something really clear and easy, which is the United States healthcare system. And if you ever wonder why conversations around healthcare here in the US, this is a simple pie chart of the different types of insurance that are out there in the market. You've heard of them, Medicare, Medicaid, commercial. But when you start looking at all the different programs, this is just high level. Medicare is broken up into accountable care organizations and Medicare Advantage. Some of the commercial markets are broken up into the VA, health system for veterans. A whole bunch of programs. But the important one is this orange section off here, which encompasses Medicaid. And Medicaid, you can see, is really a large portion. It's right up there with Medicare. So Medicare, serving people over 65 and some other subgroups, just barely, gets in there. Medicaid's number 3 behind it in terms of mandatory spending that the federal government has to do. And so the federal government actually pays for and supports a large portion of the Medicaid budget, the state budgets, which here in California we call Medi-Cal, because it's nice to have a California thing and anything that we do. So it's called Medi-Cal here. So I'll try to use both. I'll try to be consistent to say Medi-Cal. I will occasionally say Medicaid because I think of them that way just because I work in a lot of states. And so when you're talking nationally, if you say Medi-Cal, they're going to think old people. So you have to kind of qualify it. Medi-Cal is our Medicaid program here in California. And again, a lot of money goes into that. Now, what happened is a number of years back when they came out with the Affordable Care Act, you've probably heard about this, there was an expansion of Medicaid services to the states. Federal government offered to pay more of the state care expenses if they signed on. The states had to join, and they said if they did, you can, we will actually pay. And for the first year, they paid 100% and then 80%. And it's been coming down what the federal match is or how much the federal government will pay. But they did this because it was serving a certain subset of the population of the United States, and especially those at risk, those because of race, because of geography of where they were at, different conditions, which you're kind of starting to see a pattern here in how we're describing it about serving those at risk, serving vulnerable populations. But it came with a requirement that if you accepted the ACA funds, you had to meet the federal requirements for that as well. Now, not all states did. So recently, you've heard a lot of discussions about which states have joined in with the Medicaid expansion or have joined the ACA Act. And you can see the ones in orange here still are not adopting at this time. So they fund their Medicaid programs totally out of state funds for it. And they haven't accepted this expansion for it. So they're not dealing with this, some of the things that we're dealing with in how these additional funds are used. There's a lot of reasons for that, and we'll see how we do it. Are we okay on the poll, Reese? Are we?
Yes, it's been started, so.
Okay, I just want to say there's a poll here that we're going to run. Why would a state choose to not use federal funds? And it can be politics, it can be following the rules, not having ideological problems with federal handouts, and they don't believe in insurance at all. Who thinks would be the best or most correct answer?
So it looks like we've gotten a few responses. Most people are saying it's all about politics. We do have about 30% that state states don't want to expand because they would have to follow the ACA Medicaid rules. No one states that a state doesn't want to take federal handouts. And it looks like we had 1 or 2 votes for they do not believe in insurance coverage.
Well, it's good. And the poll is actually showing what we hear out when people talk about this. Why did the states that we were just showing not accept it, and why did people have reservations about joining it? All of these have been talked about. And you're right, C, not wishing to take federal money. Most states would love to take federal money, especially if it doesn't come with any strings attached. But by far, the number one reason is B, they do not want to follow the Medicaid rules. And that has to do with the rules around who is covered and what services do you need to provide as part of that. And so there's and just a lot can be, you can say, yes, people are worried about politics and people are worried about, should we do this, for other reasons, but by far, this is the reason that most states say that they're not accepting the funds, is that they're worried about what would happen if they did. And there's some good discussion around it. It's not a clean-cut decision here, because when you look at the federal regulations, it's a lot more inclusive of who can qualify for Medicaid. And they would let, in California's case, millions of people now meeting coverage to join Medicaid. Now for California, it wasn't that hard a choice because we were already making that available. We joined into the ACA Act expansion quite readily. It aligned with our politics, it aligned with our scope and current viewpoints in California. So it wasn't as big a discussion for us as it was in other states. But there's some things to remember that, again, nothing comes for free, that yes, Medicaid spending does increase significantly. And that also means when you dump millions of people into a system, do you have enough providers, beds, facilities to treat this new population of people? Also an issue, that's one of the access is the term they use a lot. You can have the insurance, but you can't find anyone to take it. They actually were some discussions about whether or not this was the new system coming with the ACA Act actually was discriminatory against the people that were already in Medicaid programs, which were the underserved, the vulnerable, the poor. There were racial disparities in care that was being addressed by that. And when you drop significant numbers of new people, which are different demographics, the people that were qualifying under the federal rules, there were distinctions about them. They were more young and middle-aged adults. They were had different employment patterns, different racial patterns, different poverty patterns, and this changes the dynamic of who can qualify and who can get services through Medicaid. It's a reasonable discussion about the changes that creates. The biggest one of all is that the money from the federal government wasn't free, and it didn't stay over time. So that means that while they were matching a lot of the increased dollars, so there's very little impact to the states in the first few years, that federal match drops over time. And that means the states have to shoulder a larger and larger responsibility of the total cost of care while receiving less from the federal government. And that is why we started having some of these other titles of what we're going to be talking about: disproportionate share and safety net hospitals. So what are we seeing now? Well, this Medicaid expansion it really has accounted now up to 14%. So they've got 14% larger patient care populations now because of this expansion in the states that have accepted it. So it's not insignificant compared to the total volume. In addition, we're also seeing with, again, we're looking at enrollment rates. More people are enrolling under the new regulations, the expansion regulations, than did under the original Medicaid program ones. So again, we're seeing it's a large percentage, and we're seeing it's growing disproportionately faster as these new populations embrace this capability. So what does this mean? Well, for one thing, what they have told you, what's kind of commonly known is that everyone thought commercial paid best, and then Medicare was next, and then Medicaids were third. You're right in some sense in terms of commercial to Medicare. If everyone in the U.S., all their healthcare was paid at using Medicare rates, we'd actually be spending what, $350 some odd billion less per year. So that's compared to all the other programs. If we went to a national Medicare for all, our total expenses would drop significantly. So, right, Medicare does pay less than others. There's a whole discussion about, is that the right payment or not? But clearly, Medicare rates are less. But what's interesting when you look at the cost in terms of revenue per day, and this is for some skilled nursing dollars, so realize there's all different types of spending. But in general, if you look at private insurance, they're pretty efficient in terms of like skilled nursing. They're spending $260 a day. Medicaid up in the upper left here, spending $204. So Medicaid spends, or basically pays, the least for the service. Commercial's not far behind. Private's at $260, but then look at Medicare here at $512. So Medicare pays really well for that in comparison. And when you talk about managed Medicare, which are the Medicare Advantage and some of the ACO stuff, when Medicare tries to reduce costs, they can get it down by $70 or $80 a day. But the takeaway from this is that Medicaid, through its traditionally low payments, and private, with their traditionally very heavy contracting ability, they pay some of the lowest rates, whereas in this particular case, Medicare is paying some of the higher rates for it. Again, it's just showing that some of the assumptions we make, it all depends on the area. This is for skilled nursing. Hospitals might be a different pattern. Provider payments might be another one. But there's this idea is that of them all, Medicaid is one of the lowest ones. So when we're looking at disproportionate share hospitals, those who take a larger percentage of Medicaid patients, the issue is their reimbursement is lower. And so knowing that, they created the idea that we should pay hospitals and facilities that take this population in greater numbers. We should come up with some way to close that gap. And like a lot of good programs for the government, the first step is they got to figure out how to measure it. So how do you decide if a particular hospital does serve the correct population? Well, they created some numbers, and if you're people like me that work in this all the time, you'll hear them talk about these numbers. This has to do with what's called the federal matching assistance. So one, we are looking at how the federal government, their contribution towards Medicaid programs, this is called FMAP, and it started off at 100%. If you accepted the Medicaid expansion, they paid for 100% of it in the first year, and 90% and then 80% as the years went on. If you look at California today, the FMAP is what should have been at 50%, but because of COVID, they gave us an extra 6.2%. So they're at 56.2%. So what started out as the federal government covering all of it, now California is shouldering half of the cost of that expansion as part of what we have to pay for the Medicaid program. And then they also have things where they will go in. Now, if with what are called enhanced matching rates, and this gets into a certain populations that they'll identify. This is something that says, depending on the mix of people that you have in your program, they will give you enhanced funding, which takes it from 50% up to 65% for those select populations. Now, again, what happened because of COVID right now, that's actually got bumped up to 80% to treat these particular subpopulations. So you get the federal matching that goes to everyone, and then they describe enhanced matching for certain populations, and all that data has got to go back and forth between the state and the federal government to determine how much they pay or give us in tax dollars to us each year. And that kind of forms the funding or the money that's coming in to cover the Medicaid program. So haven't seen any questions on the chat. And I know I'm moving along pretty quickly here. So I just want to ask, are there any questions about what we've covered so far? How federal dollars flowed into Medicaid dollars, flowing into the state, and we're seeing that we have these kind of challenged populations where the Medicaid reimbursement doesn't cover the total cost. So they address that with enhanced matching rates and other things, trying to boost that up a little bit, make it fairer for the people that are treating this population. Any questions on that? Chat. I don't think so.
I don't think so either.
Okay. Yep, I do see a comment from Kelly. Yes, the drop from full matching to the 50% that we're in has happened over, it's been 10 years. I mean, that is,
yeah, well, they came out 11.
It seems like it was yesterday
that
came out, but yeah, it's been a 10-year gradual drop. And like I said, this is why these policy agreements, these policy decisions, it's always good to understand the dynamic things that happen over time as well, and how that can influence it. And again, like I said, California was well matched to this beforehand, probably in many cases was meeting or exceeding the federal guidelines already. So we're in a little different position here in California than say other states that might have had say Medicaid programs that did not cover as many services or as many types of populations as we do here in California. So it's different in every single state. And although you can see by far, it's largely been approved by most states in here. Okay, so getting to
we did just have one question that came in.
Yes.
It was from Sean, who asked, will this reduction happen across every state?
Yes, it does. And it's not equal. So not every state's at California's level. In fact, if you look at the distribution map, some states are still as high as 80%, and other states are getting much less. It's done to a series of, I'm going to say, rules or processes that the federal government goes through each year, and they decide how much to allocate that they're going to match to different states based, I believe, and this is where I get a little gray, but it's done, I'm sure, on about quite a few different metrics that they're looking at in terms of what they're funding to the state. But I can tell you it's different for every state, and it changes every year. And traditionally, it's been kind of moving down, except as you can see with the numbers we did in a national emergency, they bumped us from 65% to 80% to help pay for the COVID costs. And that's not in the program. That was just an adjustment they made because we were in trouble. We needed money, and the federal government stepped in and said, okay, we're going to match you more. Now, realize that a match has to do with how much they pay of every dollar, meaning that the state pays the other remaining part of the dollar. So, and when you get down to 50%, that gets to where I'm putting up $1, they put up $1, and we're matching equally on it. So it's not always that simple. Usually I put up $1 and they match at 50%, so it's really about 1/3. So it's a fun math to deal with them for it. Okay, so safety net hospitals, when you look at the regulations around them, they develop safety nets facilities to identify people who serve a significant level of services to the uninsured, Medicaid, and vulnerable populations. So they can pick all three of those. Uninsured, no insurance at all. They don't have Medicaid. They don't have any insurance at all. Vulnerable populations can be those, especially in certain geographies that might be challenged. They could be rural, where they don't have access to other healthcare options. It can be different patient types. But mostly, I think it comes down to the uninsured and the Medicaid populations here in California, because again, we're pretty good about allowing people who need this kind of protection to get into Medicaid. We're using that as a primary way to make insurance available to patients, to Californians, since it benefits us all to do that. So safety net hospitals treat those groups. Now, a safety net hospital has to offer their care regardless of the patient's ability to pay. That's important. They've got to be willing to take anyone. And it has to be substantial. I mean, it has to be a significant number. And they also opened it up to many types of hospitals. So the Medicaid program here in California, which is proportionate share, covers all these uncompensated costs. So things they do because they have to do it, they got to let them in the door, but they may not get paid for it or paid enough to cover the cost of it, so they won't make profit. And to do that, but they said not only for general acute care hospitals, but also psychiatric hospitals and psychiatric health facilities. So it's not just about hospital care, but it covers psychiatric care too for it. So I wanted to get your thoughts here in another poll about, do you think that all public hospitals, knowing how we've talked about, they kind of use words like substantial and all these other words that we've used, do you think that all public hospitals are automatically safety net hospitals? And do you think that all of them receive disproportionate share hospitals? These are the public hospitals owned by California. What do you think? Are they all safety net, and do they all receive disproportionate share payments?
So it looks like we've gotten a decent amount of responses so far. We have 7. I'll wait a couple more moments to see if we have any more. All right, let's see what everyone says. So majority of the class thinks it's no for both, and then equal responses for A through C.
Excellent. Okay, well, the no and no, option D had it. It's interesting to me. It was interesting when I found this out, that public hospitals in California are not all safety net hospitals, and they do not all receive disproportionate shares. And that just says, so being a public hospital alone doesn't get you into the system. It has to do with the patients you see and their respective percentage of your overall business. And some hospitals are just in areas that they don't have the mix, the patient mix around them to qualify. It's kind of a, if you look at the 20 some odd places across the state, not all can make it. It's not something voluntary that you just say, I want to join. You, again, like a lot of federal things, they have formulas that you have to do, and it's actually calculated not by the hospital, but by the state and by the federal government. And there's, just to show that none of this is really necessarily arbitrary, they say that there are certain requirements. They say you have to, they say it goes right now to about 20, so even private hospitals can be a disproportionate share. So not all public hospitals qualify. And in fact, some private hospitals do qualify. So funds hit about 29% of the hospitals in the state, and it's covers about 25% of care for those who are self-pay without insurance. So you can see there's significant numbers in here. There's almost 30%, a third of the hospitals in the state, and we're covering some pretty at-risk populations here. but they developed two numbers, and this is calculated from their claims. This is calculated from the data that comes out when they do their claims billing, and they look at their revenue that comes out, and these two numbers, LUR and MER, but basically they're just math ways of saying, are you serving low income populations? That's the LUR, and it's the Medicaid revenue to your total patient revenue. So if you've got a lot of commercial business, and which is, that's your major portion in your hospital, and your Medicaid ratio might be down at maybe 10% of your population has Medicaid insurance, then your LUR at 10% is too low to qualify to be a disproportionate share hospital, and you're not going to be able to access these funds. They also look not just at finance, but at how many days for inpatient, how many Medi-Cal days do you have compared to total patient days? So not only do they look at that ratio of being greater than 1%, but it's got to be certain standard deviations above the mean of the state. So you've got to be not only heavily Medicaid in your day's stay, but you've got to have more than the rest of the state combined. So they're really trying to identify through these two rates, those who serve it by both financial, the dollars spent, and by, how many days sitting in a bed. And it sounds really simple here, and no, we're not going to go through the whole thing, but that is the actual formula for how they calculate MER for it. Anytime you work with a government program, I found the math to be interesting and challenging, because they try to take what is really a very complicated system and try and figure out all the things that need to be balanced in order to calculate these things fairly and with some degree of precision or accuracy across it. So even though I throw up one slide that says it's just this percentage of cases, calculating it can be a full-time job for people to do, which actually there are people that do this for their job. And I really do not want to go through that slide. That's not a slide anyone really likes to go through and all these formulas. So how good is it? We're looking at disproportionate share, and we're saying, well, it's great. We're giving extra money to those facilities that treat these underserved populations. But when you look at the payments here, the idea of how many billions of dollars, this is across the whole US, but here we're saying, well, if you look at the gap in Medicaid programs, because Medicaid pays less, there's a gap between what it costs to provide it and what they actually were reimbursed, and that's the uncompensated care gap, which you could also say could be, gotta be careful. It's not that they're losing that amount of money. This is the gap between what they expected to get and what they actually got. There's a lot of variation in that. So if someone says they're losing this much money, that's not the word I would use. What I'm saying is this is a financial gap in billing, and there's a lot that goes on in billing. So it's not like many things, not a simple discussion, but you can see that the disproportionate share payments, are only making up a fraction of the uncompensated care, and it's declining. The rate of uncompensated care into Medicaid as medical costs go up across the entire system, as our expenses go up. Now realize we're only about halfway through this graph. So this is 2021 right here. And that's probably expected, because probably only these first couple columns are true data points, but they're projecting as they look at this gap, it's going to get less and less as a percentage, as both a real number and a percentage of total uncompensated care. So it's clear Medicaid programs are going to have some challenges in the next 5 years as this gap continues to grow, as more patients join, as the payments impact the facilities. This graph here is one of the main talking points for how do we maintain a Medicaid system that serves it's a significant, it's like, was it 30 million out of 300, or no, 3 out of 30 million? I mean, it's a huge portion of our California population is served by Medicaid now through the Covered California plans and other ones. As this gap grows, and I'm sorry, the number I quoted, 3 out of 30 is not correct. I don't know what, off the top of my head, what that percentage is. This is the challenge to our system and to facilities and to providers in outpatient settings and ambulatory settings. We have to deal with this population. And at the same time, we have to figure out how to close these gaps, either by reducing the cost of care, by increasing reimbursement. And these are a lot of the discussions that continue between local, federal, and state programs about how do we allocate this. It's not a simple question. I don't have the answer to this. I can point out the problem and what some of the challenges are. This is going to be left to largely politicians, but with input from communities and input from the healthcare community as well. You know, what do we need? What can we do to address these gaps in care? As you saw in the earlier slide where we looked at commercial payments, we always thought commercial paid much better than Medicare and Medicaid. And what we're finding now is that no, commercial is in fact dropping in its overall payments. It's not the lucrative kind of funding machine that we used to think it is. Commercial's getting tight, Medicare's tight, and Medicaid's have a significant gap too. And so there's no one patient population that can pay for all of this. It's going to be a systemic issue to discuss. So when you sign up for the Medicaid expansion, basically on day one, you have to do it their way. You have to follow the federal regulations. You have to admit their patients, the patient populations that they identify. So they'll give you, there's all certain criteria of income levels and what's happening in their area and then their city, and then that would let them join the Medicaid ranks. And there's kind of a general program that you adopt. That's which services are that you must provide by that. That's that must be covered by Medicaid then. Now, what some states, including California, has done is that right away, they turned around and said, we would like a waiver. So when you hear about Medicaid waiver, what it means is it's a discussion between the state and the federal government to say, yes, we've adopted the new Medicaid rules. We would like to do it our way. And California had some very specific things they wanted to address with these expansion funds that were a little different than what the federal program is. And so they immediately went back and asked for a waiver and received it. So the federal government they had to submit an entire plan of, well, there's all these extra billions coming into the state for this expansion. Here's how we would like to do it that makes sense for California. The wording is basically the state of California has a better handle on what's important or necessary or best for the state and for our population than maybe the federal rules and regulations that cover the entire US. And so they said, we'd like a waiver to do that. And in the waiver, they are very, very specific about we're going to allocate money towards these programs, which will serve these groups in these geographies. And this is how we're going to adjust it. And that process takes months and years to go through. It is revisited every couple of years, it seems. They're doing some kind of revision to the waiver as the state of California adjusts it to different conditions. And this is an ongoing discussion. So the idea that the ACA Act started all this, and then now it's just on autopilot is really incorrect. This is a dynamic program, deals in billions of dollars moving between the federal government and us. And it's constantly amended by the state talking to CMS in ways that will help California. Recently, California received permission and has been moving with something called CalAIM. And as you move, now, if you're in practice and you're treating patients on a daily basis in your clinic, you're probably not going to hear a lot about CalAIM and what you're doing. But as you get into leadership and you start looking at the state programs, let's say here at UCI, state programs have tremendous impact on what we do here because they fund programs, they fund populations, they fund different types of care. And so again, as you're just treating patients one-on-one, what Cal AIM is probably not something you're going to worry about each day. However, for the state, trying to manage however many millions of people we have in Medi-Cal, what they're doing is they're consolidating a dozen or so different programs that were on different timeframes, serving different populations and having different programs and rules. They're trying to pull them all together into a single system that measures everything on the same timeframes. Largely, they're going to do calendar year from January through December. A lot of programs used to be fiscal year, which is July through June. And what that means is you couldn't always take the same data from the same system and kind of match it up, because things like flu has seasonality to it. It's, it spikes up in the winter, goes through the spring, and then dies off. And so depending on when you're measuring, you can get different values. And so they're harmonizing all of these programs together under Cal AIM into one umbrella managed by a single set of authorities. So they're pulling it from different parts of the state government. Used to have oversight, and they're pulling it all together under one kind of management team to look at them all together. And this should make us more efficient. It should make us able to compare and contrast between different programs and systems and compare data better. It's a multi-year commitment by the state to getting, like I said, 10 or more programs all aligned together for it. I see Kelly also, just for those not watching the chat, I'm going to go back to uncompensated, not paid by any insurance plan. So, and that's us providing care to those who have no capacity to pay whatsoever for it. So I apologize if I wasn't clear on that. Thank you, Kelly. So currently, California is operating under a Medicaid waiver, which just started. Now, this is a 5-year one, so it'll go from 2020 through 2025. Notice that it's bringing in like $7 billion in new funding. And as part of this Cal AIM project, what they're doing is trying to realign the types of quality programs we do to move from a volume, like just do it less, which was kind of the way we looked at it years back. The idea of, well, why don't you do fewer total hips? Why don't you do fewer coronary bypasses? Why don't you do less? That's kind of a volume-based approach to, or do some things more, where we want you to do more screenings. We want you to do more, particular, like more arthroscopies rather than, open up the knee kind of stuff. They were looking at volume a lot in the programs. Now what we're getting to is much more things of value, meaning we measure the outcome. And a good example of that would be that now we don't look to see, do all diabetics have a current A1C value, measuring how much their blood sugar is staying averaged over time. Now there's a particular target. We want every diabetic to have an A1C under 8%. That's our goal. And you achieve, or you receive funding if you get the majority of your population, a significant number, a target number to that level. And if you don't, you don't get it. And so they're saying, if we're investing billions of dollars in this population, we want to see tangible care changes for the better in this population. So they're kind of learning, not only should we need to figure out how to pay for the funding, but we need drivers that make us do better with the funding that we receive. And that's, for us in healthcare, that's kind of a double hit, where not only do we have to get paid for what we do, but now what we do really needs to have tangible impact. I'm not saying that it's a bad hit. It's really good. We're getting paid for our services, and they're expecting us to do well in these populations. Some of the shifts that we're seeing in the measures and some of the approaches is they're shifting away from hospital-based care, especially the episodic admission discharge cycles in hospitals, and moving a lot more towards outpatient care or ambulatory-based care. and also in-home care is becoming really an important topic for new programs that are coming up now and probably in the short-term future, because they want all these things to induce people to treat people before they get really sick, before they need hospitalization. Let's intervene while they're still in those very early stages of a disease process and see if we can keep them healthy, rather than being a system that's focused on let's get them well after they've had the full-blown disease, which we know, and or you will know soon, is something that's much harder to do when someone's down the path of having multiple chronic diseases. It's very hard, nearly impossible to get them back to health from that. It's more of managing this, stop the loss, rather than let's try and get them back to full health again. Now, some of these programs that you'll see was one that's just ending now called the Public Hospital Redesign and Incentives in Medi-Cal. It was called PRIME. That was a very large 5-year, multi-billion-dollar program. That's been replaced now with the Quality Incentive Program. But there are other ones. Global Payment deals more in rural areas. Whole Person Care focuses on getting an entire suite of services available to individuals. Dental Transformation focuses on, obviously, dental rather than medical care. And these are all things that the state is taking their distribution of Medicaid funds and saying, we want to distribute it into different topics for things that impact our citizens. And so we know dental care is not well done in the state, so they're providing more money and quality programs behind doing better at that with our patient populations. Having good dental care can lead to better nutrition, which can lead to better health, all sorts of things. And that's why this idea of a waiver means they're targeting it to the things that they see in our state that we want to close the gaps on. And so we ask for a waiver to do it the California way. So you can get this idea of how disproportionate share hospitals kind of live in this overall funding process for Medicaid, where the federal government and the state is providing extra funds to help close that uncompensated care gap. It's not perfect, but it's something. It was a lot more effective to give that money directly through disproportionate share to these hospitals that were treating the large numbers of the Medicaid population, rather than say, just why don't we just raise all Medicaid rates? Well, that would go to everyone. And again, the facilities that are bearing the majority of the burden would not get the majority of the dollars. And that's why they created these separate definitions and identified them to make sure that the dollars were directed directly to the facilities that were treating the populations having the most problems with the uncompensated care, and to try and soften some of the blow. Didn't solve it, but definitely softened some of it. So that's the end of my prepared slides. I see something in here. That's you, Kelly. If there's any questions.
Yep, I'm just here to offer a little clarifying details and whatnot. So we're just a team over here, Scott. So this is a really complicated topic, and I wanted to bring this to the forefront because when we think about policy and we think about how this system is financed, we often just think about the big ticket items. We are contributing to the national debt. We are spending this amount of our GDP on healthcare, but we don't necessarily zoom in to how the safety net is financed. And that's why I think it's really important for this talk to be, especially on this day where we just heard from Dr. Jose Mayorga on what the safety net even is, what is an FQHC. Now you know a little bit more about, from the hospital side, how those services are covered. So if you got lost at any point in this talk, we want to answer your questions here. This is meant to be a talk that is really detail oriented and really specific. And that's why I'm glad that we have someone that's so knowledgeable here with us. I think a really easy question to kick you off here, Scott, is to ask the question about where UCI is actually situated here. We have a lot of UCI medical students and undergraduates here. So you outlined a lot of the general considerations for what determines someone to be a true safety net hospital, how we colloquially call something a safety net hospital, and how that's actually a difference. You outlined how DSH funds are not necessarily automatic if you happen to care for people that show up at your door without insurance, that's actually a very specific process. So where does UCI as a health system situated with Orange County, a county that doesn't have a dedicated county hospital, right?
That's right.
How do we fall?
Well, we are one of the, certainly in Orange County, I think we're one of the, and I'm doing this off the top of my head, Dr. Mayorga would be the obvious, expert on this, but I do believe we're one of the few organizations that have FQHCs in here, and we have two of them in Anaheim and Yorba Linda, I believe. No, Santa Ana and Anaheim. That makes us also unique amongst the UCs of all things. All the UCs do not have FQHCs. It's something that we do here in Orange County. It was part of an agreement, I think over a decade ago, when we were trying to figure out how to serve this population. And so we're kind of unique in the county for our focus on it, and it's a big number for us. I want to say I've heard it's like 30 to 40% of encounters. The FQHCs see a lot of people here, and they employ a lot of people here as well. So it's a very large portion of our overall, especially primary care encounters for it. So it's and that puts certain challenges for us as an organization, both financially, how do we cover these uncompensated care gaps, and but I will say, from talking with Dr. Mayorga, I believe the FQHC is delivering care in such a way that they are revenue positive. They are not losing large sums of money, which now that's probably through disproportionate share and all the different funding sources, but they're able to, it's important. It sounds crass sometimes to talk about finances and being profitable or getting to profit. And even in a state-run institution like UCI, it's important to look at the bottom line, because that's how you fund new hospitals. That's how you fund growth. Doesn't mean it goes into someone's pockets. What it does is it goes into new services, new things we can do, and new areas we can take on that we could not have if we were operating at a loss. And so I will say that excellent work by Dr. Mayorga and his whole team in keeping those FQHCs contributing to the bottom line, serving the population they do. I don't know if that answers your question, but I want to give them a shout out. They're amazing people.
It absolutely does. It absolutely does. So we want to thank you for being with us and simplifying something that's really complicated. When you came to that slide that actually outlined some of those individual calculations, it's a moment of like, ooh, math, I forgot about this in med school. So I want to thank you for your contributions in this space, because it outlines how big this system really is. This healthcare system is not just doctors. It's not just providers. It's people like Scott that have to sit here and crunch the numbers and make sure that we as a system are doing what we need to do in order to be able to give our providers a job, even, or even keep the lights on for them delivering services in individual clinics. So it's those details around these waivers, it's those details around reimbursement that we have to understand if we're to be these systems advocates that we hope to be. So thank you for giving us that information today, Scott. We appreciate you.
Well, I appreciate it too. And I encourage people, you don't have to learn the details of the numbers, but I strongly suggest being advocates for the system. Learn about the basics, make your own decisions about where we need to go as a department, as an organization, as a state, and as a nation, and get involved, because we need input from providers and people in the system as well as people outside the system. So this does influence and impact your life and all the lives of your patients. I definitely suggest being thoughtful and being involved, if just to voice a good opinion, whatever it is, to get the discussions going.